This is our MD Anderson multidisciplinary team here. You can see probably for those of you who are patients here, you can probably see your doctor up there. We have a great team, and we're very proud of all the work that we do with medullary thyroid cancer and thyroid cancer overall. There's several of you in here who have cancers other than medullary, so we obviously focus on medullary, but also all different types of thyroid cancer, particularly patients who have a little bit more advanced disease presentation, and that's often where we see patients from across the country who come to see us. And so I do have a few disclosures. These are all related to research funding for clinical trials. Eli Lilly, Merck, and Exelixis, those are all pharmaceutical companies. We all love our pharmaceutical companies, and we do rely on them to fund some of our research, the clinical trials that we're involved in. So I don't personally get anything from this. I'm not on any kind of medical advisory boards or anything, but they do fund several of the clinical trials that we're working on for advanced thyroid cancer. So this is I think, you all are probably familiar with the American Thyroid Association 2015 guidelines. I'm on a current task force to update the guidelines to some degree. It's not going to be a full update of the guidelines. It's going to be a partial update of the guidelines, and that's led by Mimi Hu. But I'm honored to be part of that. So these guidelines are fairly old at this point, and so some of it is still very relevant. Some of it has changed over the last, 8, 9 years. In general, I always kind of like to start with, what's the general treatment for medullary thyroid cancer? I think you all are very much aware of that. It's typically, historically, and even currently, been upfront surgery, and that's typically what's called a total thyroidectomy, removing the whole thyroid gland, and also removing some of the lymph nodes around the thyroid. It's called the central neck. It's called the central neck, or level 6 of the neck. You see the picture up there that defines level 6. It's just right here in the center of your neck. And so those lymph nodes are at highest risk for metastasis with medullary thyroid cancer. So we traditionally have removed the whole thyroid gland plus all the lymph nodes around the thyroid gland in that level 6 on both sides with the surgery, with the upfront surgery. And that's what the guidelines state. They state that that's the kind of the standard. I do have to say, and somebody here asked me about this before the talk. I said I would touch on it briefly. There is some growing sentiment in studies of unilateral surgery for medullary thyroid cancer, and there's a couple of situations where kind of that makes sense. Actually, one of my patients is here who's had this done, and there's another patient who asked about it. So I know this is a question that some people have. So there have been some studies. So this is a study that was published. It's actually been 10 years ago now, from Japan. Miyuchi is a surgeon in Japan who is well known in the thyroid world, and so they've had this strategy of unilateral surgery, meaning what they do is a unilateral thyroid lobectomy, meaning only taking out half the thyroid, taking out the central compartment lymph nodes on one side, and then the lateral neck lymph nodes on that same side. So they just kind of stick with everything unilateral in patients who only have unilateral disease. They don't take out the other half of the thyroid. And so I think there's always things to learn from all over the world. So I think this is a general trend that's probably picking up a little bit of steam. Here again, we just show these are the recommendations from the American Thyroid Association 2015, and it's basically total thyroidectomy and bilateral central compartment section for all node-negative medullary thyroid cancers. Again, I think that's a little bit probably stronger than what the recommendation would be now, but that's what it was in 2015. And then, the question is, can we be more selective for some medullary thyroid cancer? So this was a paper that was published in Surgery. Actually, it was 2 different papers that was published in Frontiers in Endocrine Surgery and in Surgery relatively recently, 2022, looking at overall survival for patients who had either a total thyroidectomy, which is, if you look at the picture on the left, it's TT, or thyroid lobectomy, which is TL. And you can see that those survival curves are pretty similar for those. Then there's a second study on the right that looks same thing, lobectomy versus total. And you see the total thyroidectomy is slightly above the lobectomy in terms of survival, but it's not statistically significant. And there's probably a reason for that. There's probably a reason why that lobectomy is a little bit lower. And it's probably because patients who had more advanced disease, in some cases, were selected for a lobectomy as opposed to a total, or maybe they weren't as healthy. And so I think that's probably why that difference, but there's no statistical difference there. So this also looks at that the second study that was published in Surgery in 2022 looks at it according to age. And for those that are less than 60, it looked like there was a little bit of a difference, but for those who are greater than 60, there was no difference between a total thyroidectomy and a lobectomy in terms of survival. I think we can be a bit more selective for patients who have early stage unilateral medullary thyroid cancer. We can, for those patients, we can probably do thyroid lobectomies with a unilateral surgery, unilateral central compartment dissection, and a unilateral lateral neck dissection potentially as well. And I think that that's a trend that will be picking up steam in the coming years. And I think the other group of patients where a lobectomy or a unilateral surgery makes sense is for patients who have what we would call late stage disease. And so I hesitate to say late stage disease because late stage disease sounds really bad, but we know, with medullary thyroid cancer, even patients who have distant metastasis often live for many, many, many years with those distant metastases. So, but if you can kind of reason that if a patient has disease elsewhere in their body, let's say, with medullary thyroid cancer, it's typically the metastasis are typically lungs, liver, and bone. That's typically where we see them. But if they have maybe a little bit of disease elsewhere in their body, and then it doesn't necessarily make sense to be maximally aggressive with the surgery in their neck because we know that the surgery is not going to ultimately cure them of all their disease in their body anyway. So sometimes you can also take a patient who may be a little bit more on the advanced side. You got kind of two different paradigms. You got as we mentioned, the early stage patients who they may just have one-sided disease, and you can say, well, that makes sense to try to limit the surgery for those patients because they may not need the other half done. And then for late stage patients who similarly only have unilateral disease, it also makes sense because even if they've got something microscopic on the other side, it's definitely not any more than other disease that they may have elsewhere in their body. And so that's kind of the rationale for why I think that trend is picking up a little bit of steam. We talk about medullary thyroid cancer. We talk about the central neck, or any thyroid cancer for that matter. The central neck, which is the lymph nodes right around the thyroid. And then we have the lateral neck, which is lymph nodes that are further out from the thyroid. And we define those in different levels, 2, 3, 4, 5. You don't have to know those as a patient, but there's different sort of levels of the neck where those lymph nodes sort of live. And so, but it's kind of thought of as a different compartment than the central area. And so for patients who have lateral neck metastasis presentation, and so this is a neck, and I wish I had the pointer here, but you can see the levels 2, 3, 4, 5 with the Roman numerals. That's the lateral neck. It's out to the side here. And if there's disease there, obviously we remove that with their initial surgery. If there's not disease there, let's say we do an ultrasound, a really high definition ultrasound, and a CT scan oftentimes. Usually we do both up front for medullary thyroid cancer patients. Then if there's not disease there, then that's where there's a little bit of controversy. Like, do you still remove those lymph nodes because there is a risk of microscopic disease, or you just leave them alone? And we've taken the philosophy of leaving alone if there's not evidence of disease on imaging. Um, just a little bit of the background, in terms of, why there are different philosophies on this. So medullary thyroid cancer has more common and more extensive lymphatic spread, lymph node spread, than does um, sort of more run-of-the-mill papillary thyroid cancer. So if you think, we're all aware that the most common type of thyroid cancer is papillary thyroid cancer, and then the second most common is follicular, and then medullary is kind of down in number 3 or 4 in terms of and it's less common. So for these more common thyroid cancers, papillary and follicular, we definitely there's no controversy. Definitely don't do elective dissection, elective removal of lymph nodes um, uh, with upfront surgery. But with medullary, there's again a bit of controversy, and the reason is because we know that medullary thyroid cancer has a little bit higher propensity for lymph node metastasis. So you see with PTC, which is in this slide, papillary thyroid cancer, the central lateral neck metastasis, or, about a third have central neck, about 10% have lateral. And for medullary, central neck is much higher, which is why oftentimes those central neck lymph nodes are removed with the thyroid, and that's the standard recommendation. But then the lateral neck, maybe a third of those patients are also going to have lateral neck metastasis. And so it's higher than in papillary cancer. Which is why that some surgeons, have advocated over the years, well, we should just take these lymph nodes out because there's, high risk there. So, and that's not necessarily wrong. That used to be sort of this a more standard approach. I think, I'm going to skip this slide, but and this is kind of a busy slide. I'm going to just use it to illustrate a couple of points that kind of illustrate why the current guidelines read how they read. And also it gives you a little bit of insight into medullary thyroid cancer and calcitonin. So if you look at the blue, that's the basal calcitonin level. This was a study, actually a German study. It's actually several years old now, but it sort of looks at the data in an interesting way. If you look at the blue box, that basal calcitonin level, when it's about 20 to 50, and this is kind of at presentation, you start to see a little bit of lymph node metastasis in the ipsilateral neck, the ipsilateral central neck and lateral neck. And so, and then when you get to a calcitonin of the green box, 200 to 500, you start to see green box there, contralateral neck. You start to see a little bit of contralateral, other side of the neck metastasis. Although it's not a high rate, it's 15%. And then when you get to the red box, the 500 to 1,000, you start to see distant disease there. That's where you start to see the distant disease pop up. So those are kind of like some cutoff numbers that we use just to sort of ballpark in terms of calcitonin and what that means for where disease may be. If it's over 500, you start to have the sort of the risk of distant metastasis. If it's over 200, you're kind of looking at more lateral neck lymph nodes, and even down to over 20, you often have lymph nodes on one side of the neck. So, but despite that, it doesn't necessarily mean that for every patient that you need to do the maximal surgery, right? The maximal surgery, in general would be you remove the total thyroid, you remove the lymph nodes from both sides of the central neck, and then you remove the lymph nodes from both sides of the lateral neck. That's a lot of surgery. That's like a 6-hour surgery, and it has some potential morbidity associated with it. So we've taken the approach, and this has been an approach we've had for the last 10 years or so of not doing that. We sort of do the more minimal surgery in terms of the lateral neck. And it's worked out pretty well for us. I'm going to go, we do know that there's morbidity, and this was a study from Canada, sort of a center in Canada that was published in 2017 from Toronto, looking at 62 patients with bilateral lateral neck dissection for thyroid cancer, not specific to medullary, but any thyroid cancer. And we see that, there's a relatively high rate of complications when you do that degree of surgery. That you're talking about 6 to 7 hour surgery, and there's even, you know, um, even perioperative mortality there, is 2% in this particular study. Now, I think that's um, probably looks like that's probably one patient in this study died within 30 days of the surgery. So, but readmission rates are 1 out of 20, and so I think this is something to keep in mind for surgeons in terms of that there are consequences to major surgeries, and the more surgery you do, the more consequences there typically are. So, and then, so we, about 10 years ago, we started to ask this question: what happens to patients with medullary thyroid cancer whose lateral neck compartments are observed when we don't do that dissection, even though we know that a percentage of those patients are going to have lateral neck disease? And we don't need to go through all the details of this study. It was published in roughly 2017, but we published this study, and we basically show that it didn't really make a lot of difference whether we did the upfront lateral neck surgery electively or we just observed the neck. It didn't make a lot of difference in the disease outcomes in terms of survival, recurrence, biochemical cure, those types of things. So that's really solidified this approach for us in our minds, that we have taken a more minimalistic approach to surgery. And I think that trend, like I said, that trend will probably continue. In medicine, things are oftentimes slow to change, but that trend will probably continue a little bit for even the thyroid itself in terms of uh, doing unilateral thyroid and central compartment surgery for some patients. So, uh, with surgery, we always have to balance things. We have to balance sort of consequences of surgery with the benefit of the surgery, and that's kind of where this sort of balancing act goes in when we're considering the extent of surgery for medullary thyroid cancer. Um, Another question that we often get with when we're moving beyond the surgery is, adjuvant treatment after surgery, and what do we do after surgery? And for most patients, it's nothing, right? You do the surgery. Most medullary thyroid cancer patients, you don't need to do any adjuvant treatment after surgery. But there are some that have, certainly those that have distant metastasis, often, they'll go on drug therapy at some point. And then, there's historically been this idea that, radiation therapy should be considered for patients with advanced thyroid cancer, and medullary thyroid cancer being one of those. Radiation therapy was considered, and even, this was actually, believe it or not, before my time. This paper was published from MD Anderson, looking at radiation. This was back in the kind of the mid 2000s. So this data is from about 20 years ago. And so the thinking at that time was that, for many patients with medullary thyroid cancer, it made sense to, they presented with advanced disease. We're going to give them radiation therapy after surgery, and that was an approach that was sort of advocated, um, and this was actually published in 2008. But these were some of the indications for that radiation therapy: presence of gross or microscopic residual disease, soft tissue extension, nodal disease, mediastinal involvement. So it was pretty broad in terms of radiation. I think that the landscape of medullary thyroid cancer has greatly shifted over the last 20 years, and that's largely because, as you all are very much aware, there's now clinical trials which have validated certain tyrosine kinase inhibitors. This is vandatinib and cabozantinib, which were the two initial drugs that were FDA approved in 2011, roughly. And so around that time, there became more options for treating patients with medullary thyroid cancer. And so, and that continued to evolve. Where in 2020, we'll talk about this later, but you have the RET inhibitors, which came for those with RET mutated disease. So because there's other options now in terms of systemic therapy, that has really changed the way we think of, again, we don't want to maximize the toxicity locally, with either surgery or with radiation, when we've got options for patients in systemic therapy. And we also know that when oftentimes if a patient has really advanced disease where we would be thinking about radiation therapy to the neck, those patients typically also have disease elsewhere, right? So we don't need to maximize their toxicity to their neck because we're not going to cure them in that way. And so we've certainly changed philosophy. I have to say the 2015 guidelines, again, I think this is, again, 10 years ago almost. They're still pretty broad in their indications for radiation therapy. It still says, extrathroat extension, extensive lymph node metastasis. Those were all sort of given as reasons why somebody may give radiation. But I can tell you that in 2024, we would never recommend radiation for those reasons. And so our philosophy has really changed, where we very, very rarely recommend neck radiation for medullary thyroid cancer. And so some of you in this room may have gotten radiation for medullary thyroid cancer, and it may be that, it was because you were treated at a different era. Maybe it was, and I say even 10, 15 years ago can be considered a different era, because things have changed a lot in the last 10 to 15 years. So we looked at this. We recently published this. This was our looking at radiation for medullary thyroid cancer. And you can see how the rates from all the way back from 93 to 2019 have gone way down. And then, you can see 2018 and 2019, that was sort of the cutoff for our data in this particular study. We didn't radiate any patients for medullary thyroid cancer. And so, the last patients that we had radiated were in 2017. So we don't, and even in 2017, it was a small percentage. So, it's really evolved over the years, where we do not typically, I would say almost never, recommend radiation therapy to the neck postoperatively in a patient with medullary thyroid cancer. So there's really been a significant shift there. So these are, sort of some patient examples, patients that I won't go into too much detail about this, but patient examples of patients who, 10, 15 years ago would have been recommended for radiation therapy to the neck after surgery, whereas in 2024, we definitely would not recommend that. And so these are just some sort of imaging studies looking at sort of patients with bulky disease in the neck, which can be removed surgically, and our sort of shift in philosophy. And this is really specific to medullary thyroid cancer. You cannot, I think that there's a few patients in this room who have anaplastic thyroid cancer, and that's a completely different situation. So where we do still have to use radiation much more often. So, so we know that approximately 60% of medullary thyroid cancer patients are RET mutated. We know that anybody who has hereditary medullary thyroid cancer, you're going to have the RET mutation, and then we also know that about 50% or more, actually 60% probably, of those that are sporadic, meaning not hereditary, are going to have a RET mutation. So that's been a big focus recently for drug therapy for medullary thyroid cancer. I'm going to skip over a few of these slides because I'll address them in a talk in an hour or so. So we know that the older drugs that we had for medullary thyroid cancer that were FDA approved in 2011, 2012, cabozantinib and vandetanib, those had a lot of what's called vascular endothelial growth factor inhibition. And so we do know that what's called VEGF and VEGF receptor are overexpressed in medullary thyroid cancer, and that's one of the factors that makes it grow and spread. So targeting that is important for drugs, but it also has toxicity and side effects involved with it. So the new RET drugs are a little bit more selective in terms of their activity. These are sort of looking at different sort of receptors that are are targeted with sort of different drugs. There's cabozantinib up there and vandetanib. And so they have kind of a broad range of sort of receptors that are targeted, and the it's good in some ways because it treats the disease, but it's also, the negative is that the more sort of targets it has, the more it sort of targets normal tissue in your body too, because your normal tissues may have some of those receptors, and so that can lead to side effects. Um, so and so this is looking at, historically we could look at like vandetanib and cabozantinib, which have been around for a while. They have a lot of this VEGF receptor, anti-VEGF receptor, and anti-VEGF activity, and that can have some consequences for side effects. When you're talking about surgery, it can also interfere with surgery if you're going to give those drugs, before surgery, for example. You kind of have to consider, stopping those drugs, and there's a little bit more potential for complications. I'm going to skip over that slide because that's going to be in the next talk. So the RET-specific inhibitors have a little bit of a lower side effect profile. We know that there were two that were FDA approved in 2020, sulpercatinib and pralsetinib. Sulpercatinib has really been the one that's been continued to be marketed by Eli Lilly for the most part, although there is still access to pralsetinib as well. But so these are more selective in their targets, really targeting RET. And so in many cases, the toxicity is a little bit less for these particular drugs. And the most common side effects, for sulpercatinib are hypertension, elevated liver enzymes, diarrhea. We've also seen quite a bit of fatigue, but you see that only 2% of patients had to stop the sulpercatinib due to treatment-related side effects, whereas that's a lot higher, and we'll go over that in the next talk in the cabozantinib or the vandetanib studies. And so we have the last thing I'll mention in this talk, and then we'll have time for questions, is we are looking in some patients who present with more advanced disease. We're looking at using some of these drugs up front to treat patients. Instead of starting with surgery, which has historically been what we've done for patients with the most advanced disease, sometimes we're starting with drug therapy. And then from the drug therapy, we move to this, we shrink the disease, then we move to the surgery. And then after surgery, they may or may not go back on the drug therapy, depending on if they've got disease elsewhere in their body. And so we've used that approach. We published this first in 2020, and then we followed it with another publication in 2022. We're the first to sort of look at this, treating patients with RET-altered thyroid cancer. And we did get, about 35% tumor shrinkage in the neck. And we do think that that helped with our surgeries for these patients. And now we have a clinical trial where we're looking at that, and we'll talk about that in the next talk. But I think we'll end this talk with this slide. I think this was a paper that we published in 2024, earlier this year. So I think our overall survival is significantly improving. And these were patients with advanced thyroid disease. So we see a pretty significant improvement. The curves on the right side look a lot better in terms of survival than the curves on the left side. And so I think there is a lot that's happening in terms of certainly, I think we're honing our surgical skills, but a lot of it is also in the drug therapy realm, and I'd say that's the main reason why we've seen these improvements in survival for the patients with more advanced disease. So we're very excited about that. So with that, I think we'll stop and take questions, and then I do have another talk in an hour or two that's we'll go over a little bit in terms of some clinical trials.
Okay, Dr. Zafereo, there is one question online, but I believe you went over this earlier in your talk because I know that we have one Medi that had this. But this person said she is sporadic MTC, not RET positive, 1.2 centimeters stable nodule for 2 years, went to Mayo. They recommended a right lobe lobectomy and took one node and looked in the thyroid bed and did not see cancer. I know it was against guidelines, but they were confident that this was the correct surgery. My calcitonin has been undetectable for 3 years. I'm debating about having the rest of my thyroid out and having a central node dissection just to be sure, since I've never heard of this surgery. Should I get a second opinion?
I mean, I think it's always reasonable to get a second opinion. But I think that they probably are treating you appropriately at Mayo. It sounds like to me that this patient has a 1.2 centimeter medullary thyroid cancer that was removed with just a lobectomy, and maybe one lymph node was removed. And the calcitonin has been undetectable since surgery. So that's an example of a patient. It sounds like, again, I may not know all the details here, but a patient with early stage disease who had a unilateral surgery. I'm not sure if they knew the surgeons knew about this diagnosis prior to surgery. The only thing I would say is, typically if I'm going to do a lobectomy, meaning remove half the thyroid, I'm going to remove more lymph nodes in that because I don't want to have to go back to that area later to remove lymph nodes. So typically you would remove, maybe 6 to 8 lymph nodes for a unilateral central, sometimes more, sometimes 12 or 15. But typically you're at least 5 or 6 lymph nodes for a unilateral central compartment section. So the fact that there was only one lymph node removed, I don't know if that was because they didn't know that they were dealing with medullary thyroid cancer at the time of the surgery, but they did. But regardless, now that you've had the surgery, um, there would not be any recommendation to go back for additional surgery. Your calcitonin is undetectable. Even if your calcitonin started to rise, you wouldn't necessarily know where the disease was, and you wouldn't just want to start operating. That's not typically the answer. You want to sort of wait, let things sort of declare themselves, figure out, where that disease is going to manifest, and you don't even if you know that there's disease in the neck in patients who have had previous surgery, you don't always go to surgery right away. So in a situation where your calcitonin is undetectable, there would be no role for taking out the other thyroid lobe or for going back and doing revision central compartment dissection. I think that would be a bad decision. And I don't think that you would find, hopefully not many surgeons, hopefully not any, who would recommend that. But I think that sounds like that's at Mayo Clinic. They are in agreement that you do not need any further surgery right now. And I would, based on my understanding, I would agree with that.
Okay, the next question I have, can you provide any additional information on cases where there is no microscopic MTC in the central neck lymph nodes, but present in the lateral neck? Is this known as skip metastases? Are a majority of these cases upper lobe primary tumor?
Yeah, it sounds like, sounds like a very educated patient who actually knows a little bit about or has read some, or because that's a very sophisticated question. But yes, that's actually correct. So they are often referred to as skip metastasis because, as we mentioned in the sort of the beginning of the talk, the central neck is the area that's closest to the thyroid. And so that's where we typically think about lymph nodes going first. Sort of the second echelon of lymph nodes for thyroid cancer is in the lateral necks, which is a little bit further out. But, there are some exceptions to that. If you have a superior pole tumor, which is kind of way up here in your neck, it's your superior thyroid pole kind of goes up here and it goes a little bit lateral. It's really close to these lateral neck lymph nodes, right? And this could be for any thyroid cancer, not just a medullary cancer, but, so you're literally could be a couple of centimeters from lymph nodes in your lateral neck there. So those superior pole tumors are very close to those lateral neck lymph nodes, and proximity is the main, reason why you get lymph node spread. And so it makes sense that with superior pole tumors, you're going to more likely have early lymph node metastasis to these lateral neck nodes even if you don't have central neck node metastasis. So that's why that happens with superior pole tumors. And so you are correct. There's really, I don't know if there's any other particular question in that regard, but um, we sometimes, this is a nuance, and with patients who have superior pole tumors, I do have a little bit more suspicion for those lateral neck lymph nodes, and we make sure we really look at them closely on the CAT scan and the ultrasound. And sometimes if there are some that are suspicious or even mildly abnormal, we'll kind of remove a few of those during the initial thyroid surgery, and uh, because even if we don't have a confirmed diagnosis, because they're just right there, they're so close to the thyroid tumor. So
I have one more here from the Zoom group. This person said, I'm hereditary RET positive with pre-surgery calcitonin of 45.8 normal CEA. Tumors were found to be contained to the thyroid. I had a total thyroidectomy and right central neck dissection due to a 1.2 centimeter tumor on my right lobe. Lymph nodes removed were clear. It was found after surgery that there was a 0.5 centimeter tumor on my left lobe. My question is, given that what you presented today, would have made sense to do a left central neck dissection at the time of surgery, even though the left side tumor was not seen in
yeah,
pre-surgery ultrasound?
well, that's a good question. I mean, hindsight's always 2020. So it's, I can say a few things about this particular situation. So you have a patient who has hereditary medullary thyroid cancer. So I want to back up a second and mention something that maybe I didn't mention and needs to be, when you're talking about unilateral thyroid surgery and only taking out half the thyroid, you're really applying that to patients who have non-hereditary medullary thyroid cancer, sporadic. That's really the patient group where you're thinking about, unilateral surgery is a good option. When you have hereditary, you know that every cell in the thyroid is at risk for thyroid cancer. And so usually with hereditary disease, unless, there's always exceptions, maybe the patient has a significant morbidity or is really, really, old, maybe 95, or, something that's, you could think about a lesser surgery, but usually with hereditary medullary thyroid cancer, you're doing a total thyroidectomy because the whole thyroid is at risk. So, and it is, with hereditary medullary thyroid cancer, you have much, much more common multifocal disease in the thyroid. And as in this case, you picked up a 0.5 centimeter metastasis in the other side, which you didn't even know was there. And that's would be not that uncommon with hereditary, because you can have really, really tiny medullary thyroid cancers there that just haven't become clinically apparent. Again, because every cell in your thyroid is at risk for that, as opposed to sporadic, where it's more of an isolated, tumor in most cases. So I think the right decision was made in terms of the total thyroidectomy there. I mean, I think that's pretty clear. Um, I think the traditional, as I mentioned at the beginning of the talk, the traditional approach has been a total thyroidectomy in a bilateral central compartment dissection. So that would be kind of the standard. Now, uh, as to why that left central compartment dissection wasn't dissected, there could be, multiple reasons for that. I mean, if there was a problem with the recurrent laryngeal nerve on the right side in terms of some concern about weakness, that may be a reason, or if there was concern about the parathyroid glands. So there could be, reasons that I'm not aware of in this case that the left central compartment dissection was not done. Usually it would be done. I can say, I mean, if you're going to do a total thyroidectomy with medullary thyroid cancer, it makes sense to do both sides of the central compartment, because you really, you don't want to be going back there to do more surgery later. It can be done. I mean, it's not the end of the world, but you prefer to kind of, for each side, you kind of look at each side independently. And if you're going to take out that half of the thyroid, you're going to do the central compartment on that side. So I would say that would be the standard approach, but I'm not aware of the particular reasons why that central compartment section was not done on the other side. And so it's hard for me to comment on that more than that.
Um, I have, I'm about a year in, and I have left, so to speak, a spot on the retropharyngeal, some scattered neck nodes.
Okay.
The retropharyngeal at last July, when I first got diagnosed, was 0.3.
Okay.
It's now 0.5.
Okay.
So we're kind of on a watch.
Sure, sure.
But I'm just curious, in your experience, if you've had people with that, kind of what you've seen as progression or treatments, anything like that for that particular spot.
Yeah, retropharyngeal nodes. That's a good question. So let me just kind of give a little bit of feedback information on retropharyngeal lymph nodes. So we talked about kind of the first echelon of lymph nodes is the central compartment. Second echelon of lymph nodes is your lateral neck. If you kind of think of a third echelon, like, of lymph nodes, be your retropharyngeal lymph nodes or superior mediastinal lymph nodes. So those are kind of where we see retropharyngeal lymph nodes are not as common with medullary thyroid cancer, but we do see them. And it also depends on what exactly you mean by a retropharyngeal lymph node. And I know that you're saying retropharyngeal lymph node because that's what your doctors are telling you, but there's different locations for retropharyngeal lymph nodes. There's, some are a true retropharyngeal lymph node is one that's way up high in the neck, the true retropharyngeal area, way up high in the neck, which is kind of even above your jawbone. And that's an area that is a little bit difficult to access with surgery, but we have to remove lymph nodes there from sometimes, but we don't do it routinely. If you're pointing to your lower neck, you may just be talking about a deep lymph node that's in your central neck, called a retropharyngeal lymph node. So that's actually a little bit more common and easier situation to manage surgically because it's in the central compartment and it's not way up high, more difficult to access. So I think it depends on where that retropharyngeal lymph node is. That's one consideration. And then the other thing I would comment on, you mentioned is size. You mentioned 0.3 to 0.5. So with revision surgeries, I'm assuming you've already had a surgery, right? So you're not, a thoughtful surgeon is not going to be chasing after 0.3 or 0.5 or even 0.7 or 0.8 or 0.9 centimeter lymph nodes. I mean, the minimum that you would ever want to think about going back for a revision surgery is 1 centimeter. So and even then, I would say, even if you're at a centimeter, there's a lot of situations where you would wait. You may wait till it gets, 2-3 centimeters, depending on where it's located. So, I think the decision to do a second surgery or a third surgery is different than the decision making for a first surgery. And so, having a 0.3, a 0.5 centimeter, what's called a retropharyngeal lymph node. Again, I don't know exactly where that's located in your particular case, but the treatment would be active surveillance, not recommend any treatment for it. No surgery, definitely no other treatment for it. And then, understanding that, it's possible over the years it'll grow and you'll need a surgery. It needs to be an experienced surgeon because it's a revision surgery. And, the location of where exactly it is going to make a little bit of difference in terms of the approach. Yeah. So that's the true retropharyngeal area. So that's kind of like if you were to, like behind your throat, behind your tonsil way. But yeah. So, but, that may or may not be a metastatic lymph node. 0.5 centimeters, it's hard to tell. It certainly probably has not been biopsied because it's a difficult area to biopsy. So there's no reason to biopsy it. You just leave it alone. You watch it. You may be watching it for years, and hopefully you'll never need surgery for it. If you do, make sure it's by an experienced surgeon because that's a difficult area to access, and it requires. But for those true retropharyngeal lymph nodes, we often don't operate on them until they get to be 2 centimeters. Like we don't even operate on 1 centimeter retropharyngeal lymph nodes. We usually just leave them alone. So it's no, typically not. Typically not. We typically don't biopsy the lymph nodes, retropharyngeal lymph nodes in that location. So, yeah.
Yeah, this is a monitoring guideline question. And the question is how often to get CT scans. And the specific context is advanced disease, being treated with selpercatinib for 3.5 years,
Uh-huh.
partial response and continuing to see
Yeah.
continued response there. Getting blood work done, I think right now every 3 months for the marker.
What's the calcitonin roughly? I mean,
Less than 200.
Okay.
CPA is 25-ish.
Yeah. yeah. Okay.
So there's always a concern with the constant radiation.
Yeah, I mean, I definitely wouldn't be imaging you more than every 6 months. I mean, I think 6 months is reasonable. And I wouldn't be doing imaging more than that. I mean, it's not gonna be helpful, and it's cost and inconvenience and radiation exposure, all those things become factors. And so,
If markers are staying stable, is there any reason to not extend it out more?
you could, yeah. I mean, then you start to get into the nuances of, how long you've been stable and, but if you've been stable, relatively stable on a treatment for several years, a year or two, yeah, you're going to start moving it out to a year, right? At that point, a year scan. But, you can also, sometimes you can say, well, you know, um, yeah, I would say that, we'll leave it at that. I would say, if you've got stable disease, whether on or off treatment, the sort of the baseline is 6 months, but then we typically start expanding that to a year. I don't think you're going to get more than a year. You're going to want to look at it with imaging every year, but it certainly may be appropriate to go to yearly imaging, especially if you're monitoring the tumor markers every 3 months. I mean, you're going to know if it goes up, right? And then if you had a dramatic change, then you could go back and always do the imaging sooner.
Thank you for being here. Very enlightening. I'd like to know your opinion about the numerous people I hear getting good responses with Retevmo, and whether or not you are not aware of what your mutation is. Somehow that was skipped, and they said that the slides might have deteriorated after 12 years.
So you're saying a situation where you don't know the mutation status.
Correct.
So you don't know if you have a RET mutation.
Correct.
And but you're taking Retevmo.
Not taking it. It has been
Oh, I
suggested
see.
in the future, and I
Yeah.
hear a lot of people had positive responses with it.
I'm not aware of, and I'm not aware of everything, obviously. So there could be things that I'm not aware of, but I'm not aware of any good data, even short, small series of patients. I'm not aware of non-RET mutated patients who have been treated, have been recommended to be treated, or have shown responses to Retevmo. There could be something out there. I'm not aware of it. Certainly would not be a strategy that I think at this point that those who are the thought leaders in this field would recommend. But again, I can't say that I'm aware of every piece of data out there, but we could certainly double check and make sure that, some of the other endocrine oncologists like Mimi Hu or others haven't heard of that, but I'm not aware. I've not heard of it. And I think I would be aware of it if there were significant, you have to understand that the selpercatinib and the RET specific inhibitors is not just unique to thyroid cancer. In fact, there's more patients with RET fused lung cancer than there are with RET mutated, thyroid cancer. So a lot of what we know about RET and RET inhibition and drugs, RET inhibitor drugs, is not only from the thyroid literature and the thyroid cancer patients, but it's also from lung cancer patients. So I'm not aware of any not only for thyroid cancer, but in any cancer, including the lung, studies or data that have shown that it's effective for non-RET mutated tumors. Again, it'd be, if you had more specifics about where that's coming from, that may be interesting to know, but.
I'm not sure that he's not RET mutated.
Oh,
We
I
just
see.
are unaware of
I
what the
see.
mutation is.
Yeah. Yeah, I would say you should be able to find out if you're RET mutated, because if you've got disease and you have enough disease where you need treatment, that disease should be able to be biopsied, right? So you should know that, at least the doctor should know. The patient may not know. The patient may not understand all the intricacies, but either you don't have disease and you had disease a long time ago, and in that case, you don't need treatment, right? You're doing good. But if you've got disease, and in order to start treatment, it's got to be significant amount of disease. It's not just going to be some, small thing that you don't know what it is. It's going to have to be something, substantial, that you're going to start this drug and, take it and have the side effects and such. So if that's the case, you're going to be able to, whatever's new, you don't have to, you don't need the old stuff. You can just biopsy what's there right now. So you should be able to biopsy, like if it's a lung mass or a liver mass you should be able to biopsy that and do the RET mutation testing on that and know if there's a RET mutation. So if the patient, I mean, I doubt that there would be a doctor out there that would treat a medullary thyroid cancer that's not RET mutated with a RET inhibitor. I just don't, but I guess it could happen. I mean, there's all kinds of doctors out there. Yeah.
How long should we expect to wait for the prognosis to update with the studies and the overall survival rates looking pretty positive? Are we expecting an update on that at all?
In terms of, were you talking about for Retevmo or sulfatinib or, yeah. I think that there's going to be incremental data that's going to be coming out over time. I think, I think probably every year or two, there's going to be new studies that are going to show, longer term follow-up and will give us more and more insight into not only the initial efficacy of the drug, because the initial efficacy is one thing, but the long-term sort of efficacy and, how many patients are develop resistance and what percentage of patients are developing resistance and at what time. Yeah, I think, the last data that was updated at ESMO in 2022, that's the last sort of data that, and then there were some other studies that were presented at ASCO more recently, but they weren't kind of broad. There were specific things looking at like pediatric or brain metastases and things like that. So, but there will be, updates to those studies in the next few years. 2025, definitely not in 2024, and it would be late 2025.
And
Yeah.
that was the updated guideline question.
Yeah. The guidelines will not be released until late 2025, medullary.
Okay, I'm going to throw in one more question here. What kind of effect do tumor traits from pathology results, such as tumor necrosis or lymphovascular invasion, have on prognosis, especially when caught early?
Well, there's three things mentioned there: lymphovascular invasion, tumor necrosis, and what else was mentioned in that question in terms of prognosis? Just want to make sure I got it.
It said in what kind of tumor traits from the pathology results, such as tumor necrosis and lymphovascular invasion, what effect do they have on prognosis, especially when caught early?
Yeah, I think that's an area that's currently being studied a little bit more attention. I mean, there were a couple of studies that have been published in the last few years trying to look at some of these pathology features of medullary and sort of predicting, how those pathology features can inform, you know, the biology of the disease and how aggressive the disease is biologically. One of those is necrosis. One of them is the Ki-67, which is basically a marker of tumor turnover and how quickly the tumor, divides and grows. So there's been some studies that have been published on that in terms of, using that as prognostic markers. But I mean, the main prognostic thing I think still the best prognostic information that we have is going to be how your calcitonin is responding, that calcitonin doubling time. I don't think that there's anything that's better than that, and that provides more real-time updates. I mean, the pathology may have been a year ago or 2 years ago or 3 years ago, but what's happening right now in terms of what that calcitonin is doing, how fast that calcitonin is doubling and moving, is probably going to be your best bet in terms of prognosis. I mean, you can, all these things, you can look at pathologic features and, you can say, patients who have lymphovascular invasion, may have a little bit of increased, disease burden. But I think the main thing is looking at those calcitonin levels after surgery and how quickly they're moving.
Okay, and this is a variation on the question on surveillance when on the Retevmo. CT and ultrasound or just CT?
CT and ultrasound.
So both.
Yeah,
Okay.
well, it depends on how concerned you are about neck disease. If you're, eventually that's a little bit unique to the patient situation. So it's hard to comment in general, but I think ultrasounds are pretty easy. They're pretty simple and easy to get and do. So usually we do a CT and an ultrasound, but there are situations where, you may not need one or the other. You may not need both every time.
Thank you very much.
Okay.
Thank you very much,
Yeah,
Dr.
thank you.
Zafereo.
Yeah, thanks everybody. Great questions.